Onc Live Insights is a video editorial program produced by Onc Live.
I think the discussion regarding maintenance has to begin at the initiation of therapy. So when patients come to my office and I'm discussing with them the initial chemotherapy plan, I do begin to discuss that maintenance may be an option for them after 4 cycles of platinum pemetrexed. And I think that's very important to do, is really to outline a plan for them long term. Clearly that plan can change. But I think it's important for patients to hear up front what the intent of therapy is and what your goals of therapy are and how you're going to do it. So a patient who walks in my office, I generally discuss with them that they're going to get 4 cycles of platinum pemetrexed, and if they're doing well, they're tolerating drug, and their scan after 4 cycles shows at least stable disease, I think we should make a plan for maintenance chemotherapy. That plan can change. It's malleable, and I think it's important for physicians to understand that, but that doesn't mean that you can't lay out a plan that incorporates maintenance at the very beginning of initiating therapy.
Often, patients who have really good performance status and who have a nice response to chemotherapy and significant control of their disease are most inclined to want to pursue maintenance therapy. These patients, though, we're still seeing once every 3 weeks. They're taking time off from work to come in to get the chemotherapy. Often the toxicity is manageable, but in retrospect, when they finally do stop, they do say, you know, I had a little bit more fatigue, I had some cognitive dysfunction, I lost some of the zest I had for other things. But for them, control of the cancer may be paramount, and again, we have high-level data that shows that there's an overall survival benefit. For patients who are performance status 1 going on 2, who may have toxicities from chemotherapy, like requiring blood transfusions or more supportive care, or who may have neuropathy, the decision to do maintenance therapy, I think, is much more nuanced. If the question that I ask when I'm looking at their scans and assessing what their performance status and what their goals are is, would a minor bit of progression keep you from getting second-line therapy? If that's the case, I'm much more inclined to continue maintenance therapy. If patients have modest disease burden and even a little bit of progression would render them still active and able to get on to second-line therapy, I'll probably hold back. It's very much combined decision-making. So it's patients, it's their families, it's what kind of a burden do we want to impose on our patients, because it is a lot. We know chemotherapy works, and we don't want to undertreat patients, but we have to personalize it and do some shared decision-making to make sure it fits for that particular individual.
I think it's very important to consider patient preferences when talking about maintenance chemotherapy. Clearly, efficacy is not the only thing that must be factored in when talking about a maintenance approach. Certainly, you have to consider patient toxicity and quality of life. I think what we know from the studies is that quality of life was not affected by giving a maintenance chemotherapy, specifically pemetrexed, that this drug provided a survival advantage without a quality of life detriment. So I think it's important, though, that when we begin to have discussions with patients, that we really listen to them on how well they're tolerating it. There have been times that I have started a maintenance approach and had to stop it because patients have told me that they just can't tolerate it, or they just can't make it in, or there's too much fatigue. And I think it's important that physicians listen to their patients, because they can't be wedded to one plan throughout and not be able to change it. I think we have to be malleable as physicians, listen to our patients, listen to what toxicities they're experiencing, and make a plan based on what they're saying.
So if you think about it, maintenance therapy doesn't have to be offered to every single patient with advanced non-small cell lung cancer who has received 4 to 6 cycles of frontline platinum-based therapy. Certain patients do not need maintenance therapy. And we know those patients. Those are the ones that would like a treatment break. Not everyone wants to see us, oncologists, constantly every 3 weeks, receiving chemotherapy in our office. Some patients would rather take a break, and I think they deserve that break, and those patients are not ideal candidates for maintenance therapy. Some patients have a terrific response to their frontline platinum-based doublet. They have such a good PR or even a complete response. Or you think that those patients also have relatively indolent or slow-growing disease compared to other patients you see. Those patients may not necessarily need immediate maintenance therapy. They could potentially benefit from second-line therapy with a break in between. So those patients ought to be considered for a treatment break with close follow-up in the middle, in the middle of their course, seeing us in clinic, seeing us on a regular basis so that they don't fall through the cracks. And at the time of disease progression, we initiate active second-line therapy. Maintenance therapy is not for everyone, but it is an option that we can offer our patients who appear to be not progressing following their frontline platinum-based doublet. Maintenance therapy has to be discussed with every patient at the beginning of therapy with their platinum doublet. In my opinion, the data for maintenance therapy is robust. It has been shown to prolong progression-free survival, and in a few cases has been shown to prolong overall survival as well, whether it's used as switch maintenance or continuous maintenance. There are some nuances to this, including the histology of that patient's tumor, the patient's performance status, and the patient's own preferences, as well as that patient's comorbidities. In the end, maintenance therapy has to be individualized. In the same way as we individualize therapy for actionable targets that we find in their tumors, we need to personalize therapy in the form of maintenance for many of our patients. If the patient is seen at the get-go with a stage 4 cancer diagnosis and they have non-small cell lung cancer, maintenance therapy has to be mentioned as an option, and patients' preferences need to be weighed against their performance status, the benefits of such maintenance therapy, and their comorbidities.
In terms of cost effectiveness, I think that's important. I think physicians is an underrated component that physicians aren't great at, myself included, try to understand the cost-effective analyses of these drugs. There have been cost-effective analyses with some of these maintenance regimens. One of the ones was done on the JMIN study, which is the switch maintenance with pemetrexed, showing that in that setting, pemetrexed was cost-effective, looking at an incremental cost-effective ratio per life-year gain of about $120,000. And I think that's comparable to dialysis as the metric of what's considered cost-effective and what's not considered. So I think that I'm still learning about cost-effectiveness and trying to get a better understanding of what I'm doing. Is it cost-effective, especially in this era of budget and dwindling healthcare dollars? So I think that has to be another consideration that physicians consider when they're thinking about a plan.